Friends, today I will be speaking about blood flow restriction training, basic physiology and intervention. And this is a continuation of the talk which was taken by me in ISSEMCON 2022 on 25th March 2022. So this is just an explanation and continuation of the session which I have taken here. So let me share the slide. Yeah. So I will be talking about blood flow restriction training and the basic physiology behind the interventional physiology and also the applied aspect. And I am Dr. Hanjabam Barun Sharma, medical and clinical physiologist, as well as sports and exercise medicine specialist. And I am the president of Indian Society of Sports and Exercise Medicine. And this session was taken already on 25th March 2022. This is just a continuation of the session which I have taken, and it was taken on ISSEMCON, that is first international conference of Indian Society of Sports and Exercise Medicine, and the theme was athletic health beyond. So before going into the blood flow restriction training, we have to know certain basic physiological principle. Like, for example, any kind of the intervention, physiological intervention, exercise intervention, the purpose is always to improve or maintenance of physical fitness. And depending upon the different component of the physical fitness, we can design and target different exercise intervention. Like, for example, as you can see, it can be health related or it can be skill related. It may be cardiorespiratory fitness or cardiorespiratory fitness. It may be body composition analysis, where we want to increase the lean body mass and decrease the percentage body fat, or it may be related to the muscular strength, muscular endurance, the flexibility also, or it may be sports related or skill related, like agility, coordination, balance, power, reaction time, and speed. So these are different components of the physical fitness. So one has to understand all these components in order to prescribe the specific exercise intervention to target that particular component. So for that one has to understand this basic physiology. So let's move ahead. Moving again to the principle of the exercise prescription, because after knowing the different component of the physical fitness, one has to know how exercise has to be prescribed, how exercise training has to be done. In order to know that, one has to understand the basic principle of the exercise training also, just by remembering this word sporty. Sporty means specificity. One has to understand that exercise has to be specific depending upon SAID principle, specific adaptation to the imposed demand, and the exercise has to be progressive to overload in order to have a optimum physiological adaptation. It has to be overload accompanied with adequate recovery, so the supercompensation happens. And we already know that there is also the principle of reversibility, where if you stop loading your system, then there may be the effect of detraining effect may also be there. And according to the time, variation and periodization has to be done in order to avoid injury, in order to decrease the effect of the detraining, so that optimum physiological adaptation may be done. And a volume, intensity, or technique can be varied depending upon which phase you are giving. It may be preparative phase, transition phase, competition phase. So depending upon which phase you are focusing, then you can periodize, you can change all the training variable depending upon the time. And one has also to understand the principle of the individuality, where you have to focus on the particular individual. That is individualized, subjective, base training has to be done, because each person is different. Their adaptation may be different. So depending upon this thing, you can easily prescribe an exercise regimen, exercise training. And the exercise prescription can be done based upon this fit BP, like, for example, intensity, time, type, volume, and progression and pattern. Like, for example, frequency, how much or how frequently you are going to prescribe that particular exercise, or what is the intensity of that particular exercise, or what is the duration, how much for how long duration you are going to give, what is the type of the exercise, maybe aerobic, resistance, flexibility, or balance exercise may be done, or what is the volume is the overall exercise load. The volume is the intensity into duration into frequency. And the progression, because in order to have an optimum adaptation, your exercise regimen has to be progressive. It has to follow the progressive overload principle, and the pattern also, how you are going to adjust the all these principle the exercise pattern, so that what we want to have is a specific goal, long term as well as short term goal you have to set, and the goal has to be smart. That is a specific, measurable, attainable, realistic, and time bound goal you have to build up, so that achievable more realistic goal you can target, and depending upon a different type of the exercise, you may be able to achieve your goal, your fitness goal. It may be strength training, it may be endurance cardio, the aerobic training, it may be flexibility training, or it may be the balance training. So depending upon that, you have to you can achieve or maintain that particular fitness goal. And blood flow restriction training also, we will see later on. You have to follow this principle, because it also include in the exercise type of the exercise. So that's why this basic principle one has to understand. Now, before going into the detail of the blood flow restriction training, you have to understand certain basic physiology like enhancement size principle. We already know that, with increasing force, we already know that there is the increased recruitment, orderly recruitment of the motor unit happens. That is size principle, or principle of the orderly recruitment, which is also known as enhancement size principle. It was given by the Albert Hansman. And depending upon which type of muscle fiber, because type 1 fiber is the one which is more what you call which are more smaller, and which is more important for aerobic endurance. And but the problem with the type 1 fiber is they cannot produce much of the force. If you have to if you have to produce more force, then you have to depend on the type 2 fiber. There is no other way. So if you increase the load slowly, then you have to recruit the higher threshold, the larger force producing the motor unit, like type 2. You have to recruit it. So based upon the RM, like for example 12 to 20 less, if you are doing less than 12 to 20 repetition max, then you can basically target a type 1 fiber. But if you are doing only 6 to 10 repetition maximum, or 1 repetition maximum, or 5 repetition maximum, then you have to target the type 2 fiber. So this is the basic principle of the enhancement principle. And firing rate also same thing. The recruitment pattern, recruitment threshold, the higher one, the type 2 fiber will have a higher recruitment threshold, whereas the lower type 1 fiber has a lower recruitment threshold. In the same way, this was also given, like for example, fast oxidative glycolytic fiber. This is the fast glycolytic fiber. This is the slow oxidative fiber. So depending upon this is the type 1, type 2, and type 2X fiber. Type 1 the type 1 fiber are the one where the minimum at the minimum contraction percentage of the maximum contraction at the lower side, you will be recruiting the type 1 fiber. The intermediate will be type 2A fiber, where it is both glycolytic as well as oxidative. Whereas if you are targeting the high one at the maximum percentage of the contraction, then you have to dependent upon fast glycolytic or type 2X fiber. So this is the basic principle. So again, another important point which you have to understand is the recruitment also depend upon the speed. That is the velocity, angular velocity, like this is a radian per second. So if you see that the recruitment, as we have already seen that the recruitment, with increasing in tension, the recruitment also increases, the firing rate also increases. But if you keep at the same tension, like for example here you can see at 5 kg, then you can see that as you increase the speed of the contraction, your recruitment will increase. So the recruitment depends upon it also depends not only on the force, but it also depends upon the velocity of the contraction, that is radian per second or angular velocity. So these are the basic things which you have to understand. Another type of the interventional basic physiology which you have to understand, which you can easily apply in your practice, is regarding the importance of the eccentric training. We already know that eccentric training is very much important for muscle size also, and it has been utilized even in the elderly population, where you can see that the strength as well as fiber cross-sectional area they increases after doing eccentric training. So eccentric training is very important. But the problem of the eccentric training is eccentric training has a very high chance of the injury, as well as it has a DOMS, also delayed onset of muscle soreness. soreness. Or if you do more eccentric training, there may be a problem in the replenish of the glycogen also, muscle glycogen. So eccentric training is a double-edged sword. One has to understand when to apply, when not to apply, how to apply all this thing. And eccentric training form the basis of the plyometric and all those what you call the stretch shortening cycle, which are very much important in case of the various sports-specific movement. So eccentric training is important, but one point, practical point, which one has to understand in the eccentric training based upon a force velocity relationship is here we already know that for eccentric training, the velocity is directly proportional to the force of the movement. That if you want to increase the force, then you have to increase the velocity. So this is the eccentric component. You see that as velocities increase, the force also increases. Whereas this is opposite in case of the concentric contraction, where the force is basically inversely proportional to the velocity of the movement. Now, if you zoom out this portion of the eccentric component, and if you zoom out and redraw it here, then you can see that this is the concentric part and the eccentric part of the movement. But here you can see that since the EMG, if you are lifting a same load, if you are lifting the same load both in the concentric as well as eccentric, then based upon this force velocity relationship, then what will happen? Your activation of the muscle fiber will be reduced. This is important. Why? Because the force velocity relationship of the eccentric says that if you want to have what you call the same force, then then what if you want to go in that same force velocity curve with the same load, then this is not possible. This is not possible. You have to increase the force. You have to increase the what you call the velocity of the contraction, or either the force. Then only you will be able to move in this particular curve. Otherwise, what will happen? If you do using the same load, then you will be shifting toward this another curve where the activation is generally lower. That's why if you use the same load for the concentric as well as eccentric, the eccentric is happening when the downward that is the weight is moving down, where the eccentric contraction of the what you call the quadriceps is happening. So in this condition, using the same weight, what is happening is that since you are moving to the the different force velocity curve, that's why your EMG, surface EMG activation or recruitment of the fiber will be lower. That's why this is the practical problem which you have to face. Now, what you can do so that you achieve the same level of the activation pattern of the muscle fiber, then you can simply increase the load during the eccentric component. How much? By approximately 1.5 times the load in the eccentric, which you have already used in the concentric part. Suppose if you are using a particular weight in a concentric movement, then if you want to have the same eccentric component, then you have to increase the weight by 1.5 times of the weight which you have used in the concentric. By using that, what will happen is there will be 30% increase in the higher drive of the muscle drive will be there, and you will not face this problem of the decreased recruitment happening during the eccentric component. So many of the what you call commercially available instrument, they are started using this principle where they inbuilt the instrument is built, the gym equipment is built in such a way that you can automatically load the load the weight up to 1.5 times in case of the eccentric component, so that you basically have that optimum recruitment. So this is another important interventional physiology which you can directly apply to your practice for a better result. Another interventional physiological technique based upon what you call the basic of the strength training is what about the sequence of the exercise? We already know that the classic sequence of exercise you always do what you call the exercise, the compound exercise, multi-joint exercise. You always do first, and then you do the single joint exercise. Like for example, this is the classic sequence. The bench press, you have to do the bench press first, then you can do the leg press, then you do the what you call the shoulder press, then you can do the bicep curl, and you can do the tricep extension. So this is the basic the pattern of the phase of the sequence of the exercise which we generally do. But there is another concept. Suppose if you want to do the reverse of this, then what will happen? Then you will first do the tricep extension. Then you have to do a tricep extension. Then what you call a bicep curl. So you can reverse this process. This concept of what you call doing the first doing the exercise, the single joint exercise, before the multi-joint exercise. This is the concept what we call the pre-exhaustion concept. Now, what is happening in the pre-exhaustion? What is happening is you are, by doing that single joint exercise, you target that particular muscle, and by targeting that particular muscle, you are pre-fatiguing. You are inducing relative fatigue to that particular muscle, in this case tricep. And then when you do the compound exercise, which also include that muscle, then what will happen? Because the muscle is already fatigued, then what will happen? Then you will get the benefit of what you call a fatigue, because fatigue is always increases the muscle recruitment. The metabolic stress will be increased in that particular muscle, and since the metabolic stress is increased in that particular muscle because of the fatigue, then you may have more hypertrophy or muscular endurance in that particular muscle. So this is the principle of the pre-exhaustion. So pre-exhaustion is generally used by what we call elite player or experienced player, because they already have done all this thing and they know the risks and benefit also. Because the problem, if you do the single joint exercise first, then you will not be perform the compound exercise, multi-joint exercise later on, because you are already inducing fatigue to that particular muscle. So another concept of pre-exhaustion is, instead of doing a high intensity high load exercise, by just doing the pre-exhaustion or pre-fatiguing that particular particular isolated muscle, by doing the single joint exercise, you can do the compound exercise at a relatively lower load, but you can achieve that particular same benefit as if you are doing at a high load, because of the increased metabolic stress induced by the fatigue. So this is the principle which one can use as a pre-exhaustion, just by understanding the basic physiology. That's why the application of the physiology is very important. If you understand the physiology, then you will be able to apply that particular physiology in your field. So this is important. Another one which I want to focus before going into the blood flow resistance training is the importance of the fatigue. Now, this is just a diagrammatic representation of the muscle bicep row EMG interference pattern. You can see the electrical activity, and this is just a isometric contraction which is happening at 20% of the maximum voluntary contraction of the bicep at 130 degree of the joint elbow angle. Real part of the contraction, this is where the fatigue is happening. So you can see just by visual inspection also, the height of the interference, or what you call the bicep EMG row EMG increases. Now you can quantify this by using the RMS, the root mean square. So here you can see that in the first 50 seconds, the root mean square is relatively less as compared to the later one, where fatigue is about to reach. This is also demonstrated by the measuring of the mean and median power frequency. The mean and median power frequency classically will decrease. So this is the classic example of the fatigue. So what is happening is, when the muscle contraction is near the fatigue, then the root mean square will increase, whereas the median and the mean power frequency will decrease. This is basically where in order to maintain that particular performance, in order to maintain that particular force, then you have to recruit more muscle fibers, because of the fatigue. You have to compensate it. So this is the importance. When fatigue is induced, then in order to maintain that particular performance or particular load, here in this case 20% of the MBC, then you have to do more recruitment of the muscle fiber. More muscle fiber has to come into the play, and typically that muscle fiber may be type 2 fiber also. And most of the type, because type 1 fiber may get fatigue, so most of the type 2 fiber will you will be able to recruit just by inducing fatigue, in order to maintain that particular what you call load. So this is important. The fatigue is now how we can induce fatigue, how we can use this principle. Now, this principle of inducing fatigue can be artificially conducted by artificially imposed, artificially we can do just by applying curve. So this is the principle of the blood flow resistance training. What is happening in this principle, what we can use just apply a tonic, or you just apply a curve, and you just restrict the venous outflow. So just by restricting the venous outflow from the exercising muscle to the heart, but you are not restricting the arterial flow. So you are not restricting the arterial flow. Arterial flow is not restricted, but you are restricting the venous outflow. So just by restricting the venous outflow, you can what you call lead to the accumulation of the more of the metabolite. So your fatigue induction will be hasten. Your the fatigue will be quick. The fatigue will arise more quickly, and after some time, what will happen is there may be there may be decreased supply of oxygen and nutrients also. And because of that, one may happen is you can hypothesize that the motor unit recruitment will be more. There is more of the muscle fiber, especially the high threshold fiber like type 2 fiber will be recruited. So just by utilizing this fatigue, you may force the type 2 fiber to recruit, because we already know from the Henchman size principle, orderly recruitment principle, we already know that type 2 fiber will only come into the recruitment when the load is very, very high, or the frequency or the angular velocity of the movement is very, very high. So if you want to do a movement where the force is low, number one, number two, or you can do or the velocity is low, but you want to recruit a type 2 fiber, then how you can do? You can do by artificially inducing fatigue. So this is the principle of the blood flow restriction training, where you induce the fatigue just by applying a curve which restrict the venous return, and because of that fatigue, by using at a lower intensity, you will be able to recruit the type 2 fiber, and which may result in more metabolic stress, and because of that muscle hypertrophy, and the performance may also be improved. So this is the principle of the basic principle of the blood flow restriction training. So experimentally this has been done. Here you can see that this is just a bicep just EMG, and it was shown by Uday in 2000 paper, in their paper, where they are doing 40% of the 1 RM contractions, the intensity at the 40% of 1 RM of 20 repetition, and this is with no blood flow restriction, and this is with a blood flow restriction, and blood flow restriction was done at 100 millimeter of the mercury. So you can see that the EMG pattern get heightened. That the height of the EMG pattern increases if you do recruitment. What you call more recruitment is there if you do blood flow restriction. So without blood flow and with blood flow, so you can just see how much what you call the EMG recruitment, the recruitment of the muscle fiber increases. The integrated EMG will increase. So this is what they have plotted in their graph, where this is the relative integrated EMG, and they have done for 5 male subjects aged 25 to 40 years. And you can see that this is the what you call this one is the what you call 80% of the RM, that is high load, and this is the low load, and this is zero. Zero means what? The occlusion pressure means zero, means there is no blood flow restriction is being applied. But this here blood flow restriction is applied at 50 millimeter of mercury, and here is 100 millimeter of the mercury. They have applied the blood flow. So if you see, if you increase the occlusion pressure, then what will happen? There is no, I mean, the recruitment, the relative EMG pattern, it is approximately same. But if you see where there is no occlusion, you can see that the recruitment of the muscle fiber or relative integrated EMG is basically higher for higher load. This is 80% of RM. Naturally, it has to be high, because the muscle recruitment will happen at a higher load. So, but the problem is, if you, but the good thing is, if you do occlusion, then what will happen? Even at a lower load, this is 40% of RM, so your recruitment statistically significant as compared to at the zero load. Here, statistically significant happen at a 50% also. Here, star, you can see this is the less than 0.05. And again, also the 100 millimeter of the mercury, the relative EMG is significantly increased. That is, even if you are doing at a lower load exercise, just by doing occlusion or just by doing the blood flow restriction, you will be able to recruit more of the muscle fiber. It is shown in the relative integrated EMG. This is important. Another point, you can see that apart from the EMG, the blood, naturally blood lactate has to increase, because what you are doing is you are restricting the outflow of the venous outflow. Even though you are not restricting, completely restricting the arterial inflow, some of the arterial inflow is always maintained, but you are obstructing the venous outflow. And because of that, because of that, what is happening? There is the accumulation of the metabolite, and because fatigue is fatigue is induced very early. And here you can see, just by just by noting down this what you call this graph. You can see here, this is the relative plasma lactate concentration. This is done in healthy males, and blood flow resistance is being there at 100 millimeter mercury. They have performed two type of exercise, that is 40% or lower load for 20 repetition, and higher load is that there is ITRM 80% of the 1 RM for 10 repetition, and immediately after exercise they measure this what we call the lactate, and which is the exercise is the elbow flexion exercise, and they have basically done for the bicep brachii, and you can see that at 100% occlusion, you can see that what is happening. See what is happening. They significantly increase the post-exercise lactate concentration, only in the low intensity exercise. See, you can see, even in the low intensity exercise, if you do occlusion, then what will happen? Your what you call blood flow, because this blood flow restriction was done only in 40%, not in 80%. So if you do blood flow restriction plus at lower intensity, that is 40% of the RM, and immediately after exercise, if you measure the blood lactate, then it was significantly higher as compared to the 80% one RMC. So this is important. So lactate concentration and the lactate, because lactate hydrogen ion will be increased, lactate will increase, potassium will be increased, adenosine will be increased, other metabolite will be increased. Because of that, what will happen? There are different secondary messenger will be activated, and which will ultimately lead to the growth of the muscle, as well as other positive adaptation, as well as systemic effect will also be happen. So this is important. This is just, I just want to show this graph. That's why I put this, the importance of the lactate. Not only lactate, there are so many other metabolites also. They already increase. This is focusing only on lactate by UDI. They have also focused on other metabolites, but I have not shown here in this graph. So the basic principle is very simple. If you do if you do naturally, classically, if you do if you increase the load, then automatically what will happen? Then there will be orderly recruitment of the fiber. The first one will be type 1 fiber will be recruited at a lower load. If you increase the load, then type 2A fiber may be recruited. If you increase very high load, then type 2X fiber may be recruited. It is recruited just by following the Hans-Size principle. So, but if you do the blood flow restriction training just by applying a cuff here, then what can you do is, just by applying the blood flow, even if you are using the basic simple low load, then you will be able to recruit that type 2A and type 2X fiber also, just by increasing the restriction, the pressure of the restriction. If you increase the restriction, if you increase more occlusion pressure, if you increase the more occlusion pressure, so even if a very low load, you will be able to recruit the type 2 fiber. So this is the basic principle of the blood flow restriction training, and that's why blood flow restriction training has an immense potential of application in case of the elderly population, where they are not able to perform at exercise at a very high load because of the multiple problem. It may be joint related, it may be osteoarthritis, or any kind of the problem, or general muscle weakness, sarcopenia or sarcopenic obesity. Because of that multiple issue, you can do blood flow restriction training at a lower load, because what is happening is, just after 30 years of age, 3% to 8% per decade of reduction in muscle mass will happen. This is natural aging process. Sarcopenia will happen, and if you introduce training at a then what will happen? Then you will be able to enjoy your all age more effectively, because loss of the muscle mass, lean muscle mass, is one of the important factor for what you call all cause mortality, as well as for cardiometabolic illness like diabetes and all that stuff. So maintaining your what you call the lean body mass or skeletal muscle mass is very, very important. Similarly, not only for the elderly population, you can have you can introduce a blood flow exercise for multiple other conditions, like post-operative condition, where the joint is not able to have a higher load, or it may be astronaut, because of the low gravity or zero gravity, they will be having what you call the muscle wasting, or it may be because of the various other condition. It may be cardiometabolic condition, or a bedridden condition, or many other the case where you are not able to do high intensity exercise. Because see, the issue is 65% of RM, at least 65% of RM is required normally in case of the with absence of the occlusion. If you want to do muscle hypertrophy, this is by American College of Sports Medicine, that is at least 65% you have to do it, 65% of 1 RM. But if you want to achieve that benefit at much lower condition, like for example 30%, 20% of 1 RM, or 40% of the 1 RM, or less than 50% of the 1 RM, you can still do it just by applying blood flow occlusion. That is the beauty of the blood flow occlusion training. So the basic mechanism of the blood flow, the occlusion technique is very simple. Like I have already explained, it is because of the metabolic tension. But one has to understand this basic physiology. In order to achieve the muscle hypertrophy, it depends upon the two things, that is mechanical tension and metabolic tension. Both has to be there. The mechanical tension is more important because we have already focused on mechanical tension, especially in case of the muscle strain. The mechanical tension is very important, but metabolic tension has also an important role, like we have already seen in blood flow restriction training, where we basically reduce the mechanical tension. So mechanical tension may induce the muscle hypertrophy by it may be mechanotransduction, it may be increased production of the local hormones, or muscle damage because of the micro muscle damage. There may be increased what we call stimulation of the satellite cell, and more muscle growth will be there, and increase type 2 fiber recruitment. This we have already seen. In case of the metabolic stress will also produce various type of the hormones. It may be local hormones, it may be systemic hormones, which may act by autocrine mechanism, which may act by paracrine mechanism, or which may act by endocrine mechanism. There is recruitment of the type 2 fiber. We already saw there is a cell swelling will happen because you are restricting the venous outflow. So ultimately, what will happen? The cell will swell, and because the cell swelling, the cell is perceived it as an anabolic steroid, because cell wants to prevent its what we call damage to the cell. That's why anabolic response will happen, and there will be reduction in that catabolic process will also happen. There may be muscle damage, but most of the study says that blood flow resistance does not cause any kind of the muscle damage. But if you do blood flow resistance with high load, then there may be possibility of muscle damage. But still, there is some potential possibility of muscle damage relating control muscle damage relating into the muscle hypertrophy may be there. And there is a production of the ROS is important because they as a secondary messenger of various what we call secondary pathway. These are reactive oxygen species. So what we can see that because of the what we call there are different secondary mechanism may be there. It may be like muscle recruitment. This is mostly happening in case of the mechanical tension, and we already seen that it is also happening in case of the metabolic. Mechanotransduction may be there. It may be mechanotransduction may not be so much there in case of the metabolic stress, in case of the blood flow, or muscle damage may or may not be there. It is muscle damage is it is control muscle damage is maybe the major one of the major mechanism for mechanical tension induced hypertrophy, whereas in case of the metabolic it is not so there. The systemic and the local hormone, it is both increases. The cell swelling is the major one of the reason for muscle hypertrophy in case of the metabolic tension, but it is not so there in case of the mechanical tension. And ROS, nitric oxide synthase activity, as well as heat shock protein, which ultimately lead to the various secondary mechanism, like what we call the mTOR pathway, which is important for the muscle growth and the muscle hypertrophy. So this all happened by the autocrine, paracrine, or even in fact by the endocrine mechanism, because long-term systemic effect also there, like the production of the growth hormone we will see later on, which will ultimately lead to the hypertrophy. So a combination of the mechanical and metabolic stress is very, very important. And in the blood flow restriction training, what we are doing is we are doing a low intensity, but the mechanical tension is not so high, but still we are doing some kind of the mechanical tension is produced, but metabolic stress is very, very high. So because of the metabolic stress, even though you are giving low intensity, then you will achieve those benefits which you normally achieve at a very high mechanical tension. So this is the important. Another one, similar thing. Many authors have also given many postulates about the different mechanism of action, like what we have already seen. Because we are basically restricting the vein. venous output. Just try to understand. So what is happening, what we are doing in blood flow restriction training is we are applying the cuff before the exercise, just before the exercise, and also during the exercise. So we are basically restricting the flow of the venous. And the important point which you can do is by just for the standardization purpose, we are applying the occlusion we are applying the occlusion pressure relative to the arterial total arterial occlusion pressure. So if you that is also known as limb arterial occlusion pressure. So if 100 suppose 140 or 200 millimeter of mercury is your limb arterial occlusion pressure, where 100% occlusion of the artery happens at rest, then you are prescribing that particular the cuff, the pressure cuff, depending upon the percentage of that total what you call arterial occlusion pressure. So but the problem is we are doing that occlusion based upon the resting arterial occlusion pressure. But during the exercise, what is happening during the exercise, blood flow increases. Blood flow normally, because of the physiological the adjustment during exercise, blood flow increases. Therefore, there is no 100% arterial occlusion in case of the blood flow restriction training, and you should not do 100% arterial occlusion also because of the various potential side effects like rhabdomyolysis and all that stuff we will see later on. Another important point what you have to understand also is when you do the restriction in the blood flow during the exercise, what is it? The muscle will also contract because the muscle will just like a pump. So what will happen? The muscle will try to squeeze the blood out of the muscle also into the vein, and the vein has a valve, and that valve is the very unidirectional. The valve opens how much the blood the valve is, the arrangement of the valve is such that it opens only toward the heart. That is, the blood has to go only toward the heart because the vein has a valve system. So what is happening if you do muscle contraction at a a blood flow occlusion at a relatively lower pressure, then ultimately after some time when you do muscle contraction, then that may overcome the occlusion pressure, and venous pulsatile venous outflow can also happen. And this has an important consequence like nitric oxide synthase and all that stuff, where different secondary mechanism it will. And another important point what this author, Wilburn in 2000 is they have all actually seen is because of the venous occlusion, then what will happen? There will be, because of the venous outflow, you are preventing the venous outflow. There will be accumulation of the fluid inside the cell also. So ultimately, what will happen? Impaired membrane transfer with the contraction, increase intracellular fluid pressure. Because of the increase in the intracellular fluid pressure, the sarcomere may fail at the weakest point. This is seen because of the increased intracellular pressure will exert stress on the myofibril and leads to irregular, fluid pocket accumulation may happen, and this may elongate the sarcomere. So now what is happening is in case of the blood flow restriction, muscle damage may be seen. Muscle 100% muscle tear and all that stuff is not so common, but a type of the muscle damage, a type of the structural muscle damage which is specific to the blood flow restriction training they have reported. And here you can see that the ultimately what is happening is this is a sarcomere. This is from one jet line to another jet line is known as sarcomere. This is the M line. So from one jet line to another jet line is sarcomere. And now what is it? This is the normal sarcomere. Here is the stretching of the sarcomere happen. And stretching of the sarcomere, there is what you call elongation of the web-like characteristic is there. So if you see in case of the electron microscopy, this is a normal condition where you can see that there is no problem. These are all the striated muscle fiber, skeletal muscle fiber. But if you see the blood flow, condition, you can see that there is a wavy pattern is there. A sarcomere exhibit a wavy pattern which is unique to the blood flow, restriction exercise. So this type of a typical muscle, a kind of the you can say it is a muscle damage. But frank tear and all that stuff is not seen. But this type of the typical unique kind of the structural changes happens to the muscle after doing the blood flow training. Why this is important? This is important because of the different secondary mechanism, like I've already told, and because of that metabolic stress combined, and that metabolic stress prime the muscle in order to have increased sensitivity. You can see to the mechanical load. So in spite of the having lower mechanical load, you will be able to achieve more benefit. Like for example, here in this graph, you can see that in this first graph, this is the elbow flexion torque. That is the angular force you can measure. This is the high intensity exercise pre-training and post-training. After doing pre-training and post-training, and they have applied blood flow resistance by using a band of 33 millimeter wide and 80 millimeter 800 millimeter length. The pressure was approximately mean pressure of 110. And the exercise what they have done is they have done exercise twice a day for week for 16 weeks, and the high intensity is at 80% of the 1 RM, and lower intensity is around what you call 50% of the 1 RM. And exercise 3 set they have done, and there is 1 minute of rest between them. And for repetition for high intensity and this thing they have done up to the repetition, they basically done up to the what you call the failure. The failure. So this is this is the basic exercise which they have given, and you can see that this is the post training and this is the pre training. So you can see that the post training, there is improvement is there in case of the muscle strength. Muscle strength improvement here for a high intensity. So naturally high intensity has to be there. High intensity means 80% of the 1 RM without using any restriction occlusion. Though naturally there will be improvement of force torque, that is elbow torque. But if you see the same thing, if you see for low intensity with occlusion, you are doing low intensity, that is 50% of the 1 RM, but you are doing occlusion at approximately mean of 110 millimeter of mercury. By doing this this exercise for 16 weeks, you can see that post training there is significant improvement in the torque also, just like what you have seen in high intensity. So by using low intensity also, you are able to achieve higher torque. That means you are able to achieve more force, angular force. And this is for low intensity and low intensity without what you call this thing. And this is for the what you call low intensity exercise without any occlusion. So if you do low intensity exercise without any blood flow, then there is no significant changes was not there even after doing 16 weeks of exercise twice a day per week. Twice exercise per week, twice session per week. So even though you are doing this much of exercise for the 16 week, you are not able to achieve that what you call significant effect was not there if occlusion was not there. If occlusion was there, then statistically significant achievement was there, just like high intensity exercise. And this is the control group where you are where they have not done any kind of exercise, whether it's high intensity or low intensity. So if you do just like control group, there is no significant changes was there if you do low intensity. That is, low intensity exercise is not effective at all if occlusion is not there. So if you want to make low intensity exercise effective, then you have to add occlusion. There is no. Similarly, you can see in this paper also there is a percentage change in the muscle what you call the bone cross-sectional area. So here you can see that by using a Katsu training, blood flow resistance training is also known as Katsu training because it was first time they have done in Japan. So Japanese were the one who utilized this type of the training for the first time. So here, in case of the low intensity exercise, if you add Katsu training, that is blood flow resistance training, then there is also this with increasing days, because in X-axis there is this. So with increasing days, the percentage change in the cross-sectional area is also there. But if you don't add Katsu, that is blood flow resistance training, then if you do low intensity exercise, then there is not much so significant difference was there. Similarly, in case of the the David et al. In 2021, they have shown in their paper, they have basically compared low intensity blood flow resistance with high intensity. They have done high intensity of 75 to 80% of 1 RM and low intensity up to 30 to 40% of 1 RM. They basically done exercise for 9 weeks, and what they can see that the quadricep cross-sectional area increases. Squat 1 RM was increases both, but it was more in case of the high intensity exercise. Naturally, high intensity exercise for what hypertrophy may happen in both. Hypertrophy is equal. If you want to target hypertrophy, then low intensity exercise plus blood flow resistance is good enough. But if you want to target force, muscle force, or what you call the squat 1 RM, then what is happening is, although there is increase is there in case of the blood flow resistance training with low load, but It was more in case of the high intensity. That is, based upon a principle of the specificity. Then fiber type 2 cross-sectional area was also increased. Type 2, myonuclei was also increased, and these are the different, messengers. Like, for example, P7 to the 56K. These are important for the mTOR pathway. These are the component of the mTOR pathway for the protein growth. That is protein synthesis or muscle growth. This was increased in both ERK 1 and 1/2. Also, MYC also increases. TIF and TF1A, they are all increases. So what is important is muscle mass but not strength increase similarly between the train group, that is between the low intensity as well as high intensity, low intensity with BFR. And these are the different, what they have measured and what they have seen. The acute phosphorylation, the key protein involved in hypertrophic signaling pathway, and expression of the ribosomal RNA transcription factor occur to similar degree. So secondary messenger, they are all the pathway, they are happening similarly between the blood flow restriction as well as high intensity, and therefore low load blood flow resistance is an effective alternative to traditional high load resistance training for increasing muscle hypertrophy in case of the trained individual. So this is basically what they have seen in the trained individual. So not only in the novice or what you call the newly recruited the individuals, but in highly trained individuals also blood flow resistance training are important. Blood flow resistance training is important. You can supplement your regular training with the blood flow resistance training by doing a proper periodization, so that you optimize the gain and decrease the any kind of what you call this paper, which was also shown, the importance of the blood flow resistance training. They have generally, done in case of the, they have seen that because of the blood flow resistance training, there was a 12% more muscle mass to the quadricep muscle was seen in case of the national level Norwegian, what you call the power lifter. And what they have basically done is 25% of the one RM, they have 24% of the one RM. This is a load, and the total 4 set, first and the last set to the failure, first set and last set, they basically done to the failure, and control will be 6 to 7 set of the 1 to 6 repetition, and approximately how much, 60 to 85% of the 1 RM. That is a control group. You basically compare with that. That is one group is having a lower load at 24% of 1 RM, and another one is having a higher load, the 60 to 80% of the 1 RM. And blood flow, they have group only perform blood flow 2 out of the 6 week. That is of the total 6 week, they basically done what you call the 2 out of the 6 week. The 4 week match, because the other 4 week, the control and the experimental group, they basically train the similar way. And the 6.5 weeks is the total length of the disease, and muscle biopsy was done before and after. And just after the muscle biopsy, they can it can be objectively shown that 12% increase in quadricep muscle growth was there in case of the blood flow, but no change in case of the control group. So control group where they basically done up to 60 to 80% of the one max RM intensity without any blood flow, there was no increase, but 12% increase was seen in case of the, even though you are doing only 24% of one RM, but you are doing, there was no, but difference was not between the two groups. That means, and all the changes occur in type 1 fiber. Not see, another important point is what they have seen is that the changes what they have seen, it was more in case of type 1 fiber, and there was not much so increase in case of the type 2 fiber. So type 1 fiber hypertrophy happens after the blood flow restriction training. So this they have basically shown, and what you can see that strength gain, there was no significant difference. That means without losing strength component here, because earlier strength was relatively less, because if you remember the earlier paper, but here in this paper they have shown that strength, there was no statistical significant difference was there, but increase in muscle growth was there. So that means benefit is there, more benefit is there, just by doing a lower load with lower intensity blood flow restriction, you are able to achieve the same strength, but your 12% increase in quadricep muscle growth was there. It was but the thing is, the most of the growth was only type 1 fiber, okay, not type 2 fiber. This is what they have shown through biopsy. And similarly, in this meta-analysis, this is the forest plot in the meta-analysis in 2015, published in 2015. They have already shown that different paper they have analyzed, and they have shown that the blood flow resistance training is important for increasing in strength training when you combine blood flow resistance training with a resistance training, and there was mean increase of the 0.3 kg, in muscle strength. Similarly, for the muscle mass, also muscle size, also there is a importance. The blood flow resistance training has an important. It favors the blood flow resistance training, and when you combine resistance training with the blood flow resistance training, then there is a mean increase of 0.41 centimeter square of muscle size was increased. That means blood flow resistance training plus what you call resistance training, you are able to achieve statistically significant more muscle size, muscle growth, as well as muscle strength. Also muscle strength, there is also improvement in muscle strength. Not only muscle growth but muscle strength also you are able. That's why blood flow resistance training, you can supplement. It is a good supplement for even for going ahead with the systemic effect. Because up to now we only focus on the particular muscle where local muscle where blood flow resistance training is there. But the effect of the blood flow resistance training, it does not confine to that particular local area. It has a systemic effect also. Like ultimately, this is the mechanism which they have given. Like we already seen that because of the restriction, what is happening is that because of the restriction, there will be accumulation of the different metabolite. It may be hydrogen ion, it may be potassium, it may be AMP, breakdown product of the ATP. There is more accumulation of the lactate. We have already seen, and because of this different hydrogen ion, and because of the secondary mechanism, what we can see there, and there is also the reduction in the availability of the oxygen, also functional, what you call the availability of the oxygen will also decrease. That means 100% anoxia will not happen, but some kind of the hypoxia like effect, not hypoxia 100%, but hypoxia like effect will happen. And because of that, it will stimulate mTOR pathway, and mTOR pathway is very important for the muscle growth. It will inhibit the myostatin. Myostatin is basically the opposite of the mTOR. That is, it will not promote the muscle growth. It will decrease the catabolic pathway, and also there is the more muscle build-up, muscle growth will happen because of the heat shock protein pathway also. So heat shock, because of the heat shock protein and mTOR pathway, muscle growth and muscle hypertrophy and all the positive changes will happen. Side by side, there will be the what you call the restriction of the myostatin also. In this paper, by the same author, which was published 2009, they have also commented one important point. What they have also said that there is a basic difference between hypoxia and muscle blood flow resistance training. Because in hypoxia also, apart from different mechanism, there is also one what you call increase expression also happen in case of the hypoxia, which goes against the mTOR. It inhibits the mTOR. That is REDD1. And that is important. Why that is important? Because it will inhibit the muscle growth. It will increase the catabolic pathway. This is happening in case of the hypoxia. But that REDD1 or that secondary messenger mediator, it is not what you call increased expression is not there in case of the blood flow resistance training. Normally, what is happening is there is REDD1 and what you call the hypoxia, induce factor, hypoxia inducing factor alpha. They go hands with hand. When hypoxia inducing factor alpha increases, that also increases. And the problem with REDD1 is it basically inhibits the muscle growth. It basically causes the catabolic effect. But in case of the blood flow resistance training, we have this hypoxia induced factor increases, but REDD1 decreases or it does not increase. That paradoxical effect is there. So that paradoxical effect, because of that paradoxical effect, blood flow resistance training is not hypoxia, but blood flow resistance training has all the beneficial effect of hypoxia minus the negative effect. And another point is, since we have already shown that when you do contraction, when you release the cup also, and there is also what we call the nitric oxide, because of the shear stress, nitric oxide is production is there by the endothelium of the blood vessels, endothelium production, and some of the micro, nitric oxide synthase are also, present in the what you call the sarcolemma of the muscle fiber. Like in case of the dystrophin complex, there is a neuronal NOS, nitric oxide synthase. These are important because they convert what you call the L-arginine into nitric oxide, and nitric oxide is very important as a secondary mechanism, as well as nitric oxide is not only important for the dilatation of the blood vasodilation, but also has different secondary pathway, including the proliferation of the satellite cell. Satellite cell is the myogenic, what you call the stem cell. These are important for the growth and the maturation and the production of the muscle fiber, muscle repair, muscle fiber. In fact, satellite cell has also been indicated. Many of the authors hypothesize the satellite cell has an important role for the muscle hyperplasia also in some animal which they have shown, but not so in case of the human being. It has not been shown objectively. But because of the nitric oxide and other, not only nitric oxide, but other like what you call IGF-1, IGF-1, there is what you call the insulin-like growth factor 1. Because of that, there is satellite cell, what you call proliferation, and all this happen. Another one is they also stimulate because of the hydrogen ion, because of the intracellular hydrogen accumulation, there is acidity and other, other chemical messenger metabolite which accumulate because of the blood flow. They stimulate the what you call the nerve fiber. There is the type 3 and the type 4 nerve fiber. What you call the this is also known as what you call the muscle exercise or pressure effect, or chemo reflex pathway, or what you call muscle chemoreflex pathway, or exercise pressure reflex. And because and this nerve fiber, what is they go all the way to the what you call our anterior pituitary, in the brain, anterior pituitary, and that will lead to the production of what you call a growth hormone. And this growth hormone, 290 times as compared to the baseline, there may be increased production of the growth hormone may be there. So growth hormone, so much supraphysiological concentration of the growth hormone has been proposed, has been documented by some of the authors. And not only this pathway of by this fiber, but also by various systemic effect of like hydrogen and all that stuff. And there is increased production of the growth hormone. This growth hormone will lead second, the other like IGF-1, which are important for muscle satellite cell proliferation, as well as, for example, this growth hormone is also important for the synthesis of the collagen, and this collagen is important for the muscle function and muscle growth and function and maturation. And that's why you can see that the effect of the local effect of the blood flow resistance training is not local, it is systemic effect. That means you are doing obstruction somewhere, but you may get beneficial effects in some other muscle also. In fact, in the brain also, and different parts of the. That's why blood flow resistance training has been hypothesized to increase what you call the cognitive function also. Cognitive function also, not only muscle, but also other, organs, especially the cognitive function also they have. So similarly, this is the another author had proposed this function also. Like we have already seen that there is increased muscle hypertrophy happens because of the blood flow resistance training, and there is increased production of ROS. There reactive oxygen species will happen, and the problem is the reactive oxygen species will happen, but there is ionic and redox buffering capacity will also improve. And oxidative capacity, of the muscle will also improve. There is increased capillarization may also happen, and if you see, the cardiovascular changes, then you can see that there may be systemic. It is maybe question mark is there. That means it may be hypothesized that there may be increased systemic oxygen delivery may also happen, and there is increased conduct and resistant vessel function will happen, because during the exercise the blood flow is there. But if you do blood flow resistance, if you just remove the cuff also, and during that time also there is the reactive hyperemia will happen, and the nitric oxide synthase activation and nitric oxide production may also be happen. And because of this different function, so we can see that their blood flow resistance training, the effect is not localized, but it has a systemic function also. So similarly, the another author, that is Nina, they have also proposed this mechanism especially for diabetic also, because of the diabetic, in case of the diabetic, although they have they have proposed that the blood flow restriction has important potential use. We already shown that the blood flow restriction, here in this case they are doing quadricep exercise. Blood flow restriction is applied proximal to the lower limb, and because of that there may be increased calcium influx, and this calcium will activate lead to the activation of the calcium calmodulin kinase, and along with the AMPK kinase, this will lead to the increased translocation of the GLUT4 receptor to the surface, and this will increase the what you call the insulin sensitivity. It will increase the glucose uptake by this thing, and also there is production of the ROS production also there. Because of the ROA production, there may be increased what you call insulin production may be there, or increased glucose uptake is also there. Neuronal nitric oxide synthase activation is there. Because of the nitric oxide increased productivity, there may have a satellite cell activation will happen, and this satellite cell will fuse to the muscle cell, and it will help the repair of the muscle cell, building of the muscle cell, hypertrophy of the muscle cell will happen. Then we already seen that there is a growth hormone production is there from the anterior pituitary, and this growth hormone will act in the muscle, and it will help in the building of the collagen synthesis, or it may via liver it will causes the production of the insulin like growth factor 1, and also because of different metabolic accumulant, we have already seen that there is the activation of the group 3 and group 4 afferent fiber in the muscle, and there is also recruitment of the first with the type 2 muscle fiber recruitment will also be there, and which ultimately lead to the production of the muscle mass, muscle hypertrophy. And because of the pulling also and different mechanism, we have already seen that cell swelling and the metabolic will lead to the what you call decreased catabolism pathway is inhibited, whereas the MAP kinase and mTOR mediated muscle, or what you call build up is there. There is mTOR and this thing is there. Okay, so just by the use of the what you call the blood flow resistance training, ultimate effect is the muscle hypertrophy may be there because of the mTOR. mTOR is the mammalian target of the rapamycin, which is very important for the muscle growth. Another is the MAPK kinase, that is the mitosine activated protein kinase. These are important, has an important role for muscle growth. And what the same author, what they have suggested that they have suggested a protocol for how it can be used, general protocol, like for example frequency they can do up to 2 to 3 times per week. That is minimum more than 3 weeks they can use for more than 3 weeks, or 1 to 2 times per day they can also use up to say 1 to 3 weeks they can use. The load has to be lower, it has to be less than 50%, that is around 20 to 40% of the 1 RM. Restriction time, it can be up to 5 minutes. You see, the most important point is you are not 1, 2, 2, 3 point you have to understand while doing blood flow resistance training. You don't have to increase the load. You don't have to, because if you increase the load with restriction, then problem will happen, side effect will be there, and you don't want to that restriction, keep that restriction for a very long time. No, you don't want that. Otherwise there may be other complications which we will see in the later slide. So approximately 5 to 10 minutes per exercise. That's after exercise you release it. You can do continuous blood flow restriction during when you're lifting, during all the repetition you can do, or you can up to 1 set also, or you can release between a set also, what you call the alternating or pulsatile, what you call the BFR training. So and the repetition, this is the typical repetition, that is 30 rep repetition you do, then after that 15 repetition you do, then 15 repetition you do, then 15 repetition you do, or up to the failure, that is volitional failure you can do. This is the typical classic set which we use in case of blood flow, and the rest between the set is kept around 30 to 60 seconds, because you want that metabolite to accumulate as much as possible. And the limb occlusion pressure may be 40 to 80% of the arterial occlusion pressure. So 40 to 80% of the maximum arterial occlusion pressure at the resting condition you can apply. Just by using this principle you can apply what you call the blood flow restriction training. This was given by that author. This is general principle, but you have to modify according to the type of the patient. Individualization is very important. So proximal effect is important. Like for example, if you apply like I've already told you that blood flow restriction has so many what you call the systemic effect also. Like it may be because of the paracrine, it may be because of the autocrine effect, it may be paracrine, or it may be endocrine signal may also be happen. And this is the, if you do the blood flow restriction here, then what will happen in case of the proximal, the muscle which is proximal to the what cuff, you are getting benefit not only to the muscle distal to the cuff, but also to the proximal to the muscle. Like for example, increased muscle activation will happen in case of the muscle which is proximal because of the downstream fatigue which is there, or because of the proprioceptive mechanism. And increased mechanotransduction may happen. There may be increased metabolic signaling released during the cuff. If you release the cuff, then more metabolite will be released to this direction, because and there may be increased systemic anabolic effect also. Because of this effect, then the muscle which is proximal to the cuff will also get benefit. And for example, the distal, we already know that there is an increased metabolic stress is there, metabolic stress is there, metabolite accumulation is there, and metabolite accumulation is also there during the exercise. And if you release also, it will be there. And there may be increased what we call hydrogen ion. Because of that, there will be a decrease in pH, and increased carbon dioxide will be there. Lactate, calcium, and what you ROS, their reactive oxygen species will be there. Increased myokine release, different myokine, increase release, hormone released by the muscle will be there. Mechanotransduction will be happening because of the cell swelling, and there is a local increase of the IGF release also, like insulin-like growth factor release also. And because of this different mechanism, there is increased potential disease via different intracellular pathway, mostly because of the two part. There is mTOR-C1 and AMPK kinase, like I've already explained. There is increased satellite cell differentiation may be there because of the nitric oxide, because of the IGF-1, because of the IGF, insulin-like growth factor. And there is also increased osteogenesis through muscle-bone cross signaling. Because of the muscle-bone cross signaling, there is increased osteogenesis also. These are the different potential, benefit of the blood flow resistance training, just by understanding the different, what you call the basic physiological mechanism. So here also this author, that is Torpel 2018, they have also reported the different thing. Like for example, blood lactate, we have already seen. IGF-1 growth factor, VEGF, that is what you call the vascular endothelial growth factor. HIF, that is what you call the hypoxia inducible factor. And these are all chemical messenger